Good evening and welcome to tonight's clinical seminar, Differentiating Bipolar Disorder and Trauma in Clinical Practice. For those of you who may be new to CMHRC, I'd like to take a moment to introduce myself. My name is Elizabeth Errico. I am the founder and executive director of the Children's Mental Health Resource Center. Our mission is to provide guidance and resources for early identification and management of mood disorders, bipolar disorder, and the newly recognized bipolar subtype known as fear of harm, officially named thermoregulatory sleep dysregulation disorder. We fulfill this mission as a 501c3 nonprofit organization through a combination of programs and services that we offer to families as well as to providers. That includes our palliative parenting classes, which are available both as face-to-face and on-demand self-guided video courses that take parents through the basics of how to effectively parent, discipline, and limit set with children who have mental health challenges. We also have our ketogenic therapy in action program, which brings low risk, potentially high reward at-home interventions to families that they can begin today, right away, without a doctor's intervention. We also have our CMHRC Toolkit, which is a custom-designed web app for parents to use to track symptoms, medications, mood tracking, and diagnosis of their children. This app also is available for prescribers and mental health providers in general as a way of being able to communicate in real time with their patients and clients about how they're doing when they are not in your office. We also have our Wayfinder services, which are high-touch, personalized support around things like diagnostic consultation, helping families understand diagnoses that they've been given, helping providers identify diagnoses that are accurate within a complex case. Our community advocacy and consultation, which provides community support to families as well as providers, and our interdisciplinary professional discussion groups, which meet monthly. As I mentioned, we are a 501c3 nonprofit organization, and we fulfill our mission not only through the programs and services, but through the support of the people in our community, be you a family member, a provider, a occupational therapist, a speech therapist, physician, mental health provider, whoever you are. If you are enjoying any of our free services or resources, please consider making a gift. We are running a campaign all year, Give 25 in 25. You can use this QR code to take you directly to our safe and secure online giving platform to make a gift of 25 in 25, either as a single one-time gift of $25, which is greatly appreciated, or any $25, $125, $225, you name it, sky's the limit. But a gift of $25 one time is greatly appreciated. But recurring monthly gifts of $25 are also appreciated. They allow us to plan our service offerings and expand them when we can. And recurring monthly gifts allow us the financial stability to be able to predict what we can and cannot invest our time and resources in. So we ask everyone to consider making a gift in 2025. Now, tonight we're here to discuss differentiating bipolar disorder from trauma in clinical practice. And we get this question a lot whenever we're talking about bipolar disorder and its unique presentation in children. We get asked over and over again, how can you know that it is bipolar disorder and not just a response to trauma? And so we've dedicated this whole seminar tonight to this information. And so our learning objectives are going to include identifying 2 misconceptions about bipolar disorder versus trauma that can cause confusion in differentiation. We're going to recognize 3 key differences between mood disorders in general and trauma disorders as a basis for understanding them. We're going to explain key differences between bipolar and trauma. And we're going to identify overlapping symptoms and differentiating how these symptoms appear as aspects of either bipolar disorder or trauma. And we're going to describe the gold standard for diagnostic assessment and appropriate treatment for managing each of these serious conditions. Tonight, I have with me as my guest my colleague, Angela Jameson, who is an expert in trauma. And she and I are going to be discussing this differentiation between the two with you all as we go. Now, what we're going to ask is that you put any questions you may have into the Q&A. I will be monitoring that as we go and integrating questions when I can into our conversation. And when I can't, we will hold those questions until the end and answer them during the live Q&A session. So if your question isn't answered immediately, please be patient with us. We will work it in. And in the meantime, if you have questions about how to receive a certificate of attendance for this event, please look to the confirmation email that you will get from Zoom tomorrow, confirming your attendance. There will be a link in there for you to purchase that certificate of attendance for a $5 preparation fee. So without further ado, Angela, welcome. I'm so glad to have you with me here tonight. We are going to be talking about differentiating bipolar disorder from trauma. And so I'd like to start out with sort of identifying broadly some of the misconceptions that lead to this confusion in the first place. And the first is that trauma is always a preceding factor in mental illness, that it's somehow a trigger, that when we're looking at symptoms that are emerging in childhood or adolescence, the assumption is that something, quote, had to have happened to create the behavior in children. So I'm going to start by lobbing that question at you. Where does that come from? And how do we understand it in the context of actually recognizing the difference between these two disorders?
Yeah, I think often people want to think that it has to be one or the other. But the reality is that comorbidity, meaning the two can happen together, is a thing. And although childhood adversity, or in the trauma world, we say adverse childhood experiences, um, is a known risk factor for bipolar, it does not mean that every person with trauma, early childhood or otherwise, is going to also have bipolar. Early trauma can predispose children to the early onset of bipolar based on the way that their genes have adapted to the stressors that they have experienced. We call that epigenetics. And it can also be passed down from the way that their parents or grandparents responded to stressors. But again, this doesn't mean that it's going to be a pair. I think people often get caught up in that thinking that it has to be together. It's either trauma or it's either bipolar. It can definitely be both, or it could definitely be a single one or the other.
I love how you've sort of stated something that's very, very basic, simple, easy to understand, that it can be both. You know, when we talk about bipolar disorder or mood disorders in general, because of course having a traumatic experience doesn't necessarily mean you're going to develop any mental illness at all. It can also, as you pointed out, have these interact with these epigenetic triggers and lead to some sort of disorder. But I think we specifically see this kind of misperception around certain types of symptoms. For example, in bipolar disorder, there are depressive symptoms that when a child is withdrawn, when a child is tearful, as adults, especially when they are younger children, we are looking to the environment to try to figure out what is causing this child to be withdrawn and tearful. And the fact of the matter is that when we're talking about a mood disorder and bipolar disorder in particular, there may not be any externally identifiable preceding event, because bipolar disorder is, by its very nature, a chemical disruption in the brain, in the gut. It's being conceived of most recently as a metabolic disorder. Those aren't things that can be observed externally, and therefore are not going to be exclusively determined by anything that's happening in the environment. And so that's a case where being able to sort of drill down, and we'll talk a lot more about this later, but really drill down on the cause of the symptom that we're seeing is really going to give tremendous insight into what the correct diagnosis is likely to be. That also leads to our second misconception, which is about mood swings. Mood swings are often seen as evidence of trauma. They can also be seen as an indication that there is some sort of mood instability that could be pathological and require diagnosis. What are your thoughts on this idea of mood swings being indicators?
So mood swings can be part of trauma. They can be part of bipolar, but I think sometimes we put these blinders on when we're looking for one or the other, or we're looking at our children and we're like, something's going on. And the reality is that mood swings are also just part of normal growth and development, right? So as children and especially adolescents are growing, their brain is growing with them. But what's happening is the prefrontal cortex of their brain, which is the part that's helping them make good choices, the part that's helping them with problem solving, logical thinking, working memory, attention, all of those really important details, that is growing slowly. And simultaneously, the amygdala, which is the part of the brain that is controlling emotions and pleasure, it's growing much more rapidly. And so, what's happening is this gap in growth between the two can be quite dramatic. And the amygdala, that's controlling all of the emotions, is bigger and stronger than the prefrontal cortex, which is saying, whoa, slow down. That's not really what happened. Or maybe we should think about this. And that is creating mood swings, emotional outbursts, and that instability that you see. So really, it's quite common just as a part of life and development.
You're talking about sort of what I refer to as developmentally expected behaviors, and that they are pervasive for this age group, regardless of whether or not there is an additional diagnosis of trauma or of a mood disorder. Um, but again, I feel like I'm going to sound like a broken record already, but this can also occur as a result of other underlying medical conditions and biological factors that you touched on. You know, for example, having an underactive or overactive thyroid can also produce some kind of mood disruptions. It can cause exhaustion. It can cause kids to become withdrawn, inactive, and display symptoms of depression or even hypomania. And so this is one of the reasons why whenever we hear parents talk about mood swings, we really ask them to talk about, are there external things that are triggering? Have they had a thorough medical review by their pediatrician? Have they had blood tests done to determine whether or not there is some complicating factor? Because and this, of course, is one of the reasons why in the DSM, all diagnoses have as a characteristic and diagnostic criteria that we have ruled out some other general medical condition, because mood swings not only can be developmentally expected, they can be the result of a medical condition that needs to be addressed. And just to share a little story anecdotally, there's a family in our community where the parents talk about the fact that they have this child who has had a mood disorder their whole lives. And now they're suddenly teenagers and having to parse whether or not the mood disruption or the symptom manifestation or behavior is actually under the child's control or not. Um, the parents will say to that child, are you experiencing a symptom? Do you need our help resolving this? Or are you being a regular teenager right now? And that particular teenager has been stable long enough that the parents can have this kind of joking back and forth with them. But it gets to the heart of the issue of, is this something that is happening because developmentally teenagers can be argumentative with their parents, or is this something that is happening because they don't have any control over a symptom, or they're having some kind of trigger associated with their trauma?
I think that that is a huge point to think about, right? When we have children in our home who are acting in a way that is different from what we might see in society or what teachers might say is appropriate or what our parents say is appropriate, um, we're we're constantly trying to find the reason because we want to fix it, right? And so it's important to step back and be like, maybe the reason is just because they're a teenager. Maybe the reason is just because they didn't sleep well last night and they're grumpy. It's not always the big ordeal that we sometimes worry it might be.
Absolutely. So let's move on to sort of talking about some key differences between mood disorders and trauma disorders as sort of a basis for understanding them. And I'm going to start with talking about sort of onset, the pattern, the duration of symptoms. And so in the case of bipolar disorder, we use the term in mental health, we use the term prodromal to describe the beginnings of a disorder. And so very often in bipolar disorder, when a family is going through an evaluation process and the child is being evaluated by a mental health professional, we are asking these important questions about history, because sometimes it's only after the fact that we're able to identify that these symptoms that are being presented with intensity today actually first started emerging 2, 3, 5, 10 years prior, but they were smaller. They were less intense, they were less frequent, but they were still present. And so being able to do that sort of historical review, we see that with bipolar disorder, the symptoms that we're using as part of the diagnostic process were present usually for an extended period of time or a prodromal period prior to sort of the full-blown escalation of symptoms that would justify a diagnosis. And so that's sort of a key piece about how we look at onset and symptom patterns for bipolar. What is it like for diagnosing trauma?
Yeah, so that extensive history is going to be just as important. But with trauma, what we find is that onset is typically going to be after a preceding event. Something has happened to start this process. There are times that there's delayed onset, perhaps even years later, if an individual has suppressed feelings. But you're still going to be able to track it to this event that happened. Pattern and duration are going to look very different for each individual, right? Depending on their brain and body's response to the trauma, because everybody experiences it differently and experiences those symptoms differently. But what we should see is that once it's addressed, once they have appropriate treatment, and they are, getting psychotherapy or whatever that looks like for them specifically, individuals should really see a decrease in those symptoms, and an increase back in the sense of control of their life.
Okay, so that's onset, the pattern and duration of symptoms. The second identifying factor that we're going to look at is internal versus external, right? And we come back to this all of the time because bipolar disorder, mood disorders in general, their symptom presentation is rooted in reactions to internal and biological states that are occurring. So, for example, when I referenced earlier that modern conceptions of bipolar disorder are looking at it as a metabolic dysfunction, something that has to do with how our cells, mitochondria, use, produce, distribute energy for us to use. And so many researchers nowadays look at bipolar disorder and other mood disorder symptoms as being energy disorders, that the classically described depressive symptoms and episodes associated with depression are simply a decrease in available energy, whereas hypomania and mania are responses to excess energy in the system. And so this idea that biology really plays a role in the symptoms presentation of bipolar and other mood disorders is really important because these are internal biological functions that are occurring outside the control of the individual. And so very often that person feels as though they have these involuntary symptoms that are occurring that they are sort of washed away by. And that may be similar to the individualized experience of a trauma response. But at the same time, here, what we're talking about is the cause is coming from something internal that is unobservable on its biological level. Now, Angela, is that different in trauma?
Yeah, so trauma is going to be a response to an external trigger in the environment. There is a precipitating event. There is something that created and started this process. And I noticed in the Q&A that someone asked if there is a list to share regarding the different types of trauma in children. And sure, I could name off abuse, neglect, all of those things. But the reality is, it's really important to note that an event will not affect every person the same way. So trauma is a response to the effects of how a person experienced a specific event. So something might happen to one child and it doesn't affect them at all, but another child internalizes that and it becomes a traumatic response. A kind of good example of this is thinking about the COVID-19 pandemic, right? We were all part of that event. However, our experiences were probably very different. Maybe you got to stay home with your family and you really enjoyed that quality uninterrupted time. But I was an essential worker and I had to go into work during the virus. And I actually watched, this is not a true statement, but I actually watched several of my friends die from the virus during our work time. So those are very different experiences to the same event, and they're going to affect each of us very differently. So the effects are likely going to be more detrimental and traumatic for me, who was in knee deep in the thick of the virus, and you probably will be able to establish appropriate coping skills to work through any feelings that time period caused. So, yes, there are classics things that we think of when we think of trauma. And if you want to look up Kaiser Permanente's Adverse Childhood Experience Study, they list 10 very specific items that can happen to children in early childhood traumatic experiences. And again, that includes abuse, it includes neglect, it includes having a parent incarcerated, it includes the death of a parent. So there are a number of things that we can name for that list. But the reality is, just because it's traumatic to me doesn't necessarily mean it's going to be traumatic to you.
Angela, thank you. And I'm actually going to throw into the chat a link to that document that Angela just referenced, the Kaiser Permanente list of adverse childhood experiences. Angela, I think this might be a good opportunity to sort of pause for a moment and ask you to talk a little bit about the difference between sort of a singular traumatic event versus repetitive events that, what's the word I'm looking for, collectively become trauma.
Yeah, so someone in the chat just said my daughter told me that she was traumatized because her dad had charged at her as if he was going to spank her for expressing herself, and it was traumatic for her. So that caused a flight of emotions in her. It caused her amygdala to say, "Whoa, something is dangerous." And we all have events in our life that are one-time situations that can cause trauma and then trauma symptoms, right? Maybe it's a car accident, maybe it's um, a natural disaster. But the part that can get really detrimental is if we're experiencing those events over and over again and not getting the help we need and not allowing our body to get out of that stress response. And so when we're looking at continued abuse or neglect or situations that are happening over and over again, the trauma experience of that is can be far more significant because your body's staying in a state of being afraid. And so that is affecting everything going on internally as well as how you are portraying things externally.
Thank you. Thank you for explaining that. The third difference that we have between bipolar and trauma that we want to look at is medications and therapies. And this is sort of more focusing on once we've identified the difference, how do we treat it? But oftentimes in our system, we have cases where we are essentially testing out a diagnostic theory through the use of medication. And that happens commonly with bipolar disorder, because in bipolar disorder, there is a reluctance of many providers to provide the diagnosis of bipolar disorder to children. And so very often, insurance companies, large hospital systems, they have as part of their formularies for treatment that certain medications have to be tried, and the child has to, quote, fail on that medication before they can give the diagnosis of bipolar. So while we believe that that is an unethical approach, and that it is not the child who is failing, but the medication, it is still a practice that is common. And so when we talk about identifying bipolar disorder, identifying it does involve understanding the medications that are used. So to treat bipolar disorder medicinally, we're looking at the gold standard treatment, which is to start with a mood stabilizer. Um, these medicinal interventions that involve SSRIs, that involve stimulant and medications, those are the ones that children are being given in order to demonstrate whether or not they have bipolar, because they will have adverse reactions to both SSRIs and stimulants at levels that would be therapeutic for other disorders. But for bipolar disorder, once they reach those what should be therapeutic levels, in bipolar disorder, it produces adverse reactions. It can trigger mania, it can trigger hypomania, it can trigger mixed episodes, which can lead to self-injurious behaviors. And so, or symptoms, I should say. And so when we're talking about bipolar, we're looking at mood stabilizers, the use of lithium, of trileptal, which is the generic is oxcarbazepine, lamictal, the generic is lamotrigine, and others that are proven mood stabilizers, proven to be effective in treating bipolar disorder. From a psychotherapeutic standpoint, we look at the fact that CBT, cognitive behavioral therapy, does not work as an effective strategy for treating bipolar disorder when the person is highly symptomatic. It can work later on in the treatment process once mood stability has been achieved, but cognitive behavioral therapy cannot work to reframe any faulty cognitions or to modify any behaviors, because those symptoms that they're experiencing are involuntarily biologically based. And so you cannot reframe a mitochondrial dysfunction cognitively. You can't simply decide to have your mitochondria release more energy. And so using more somatic based interventions such as DBT, which teaches a person how to identify what's going on within their bodies and how they can intervene effectively, is going to be a much more effective treatment modality than CBT. Uh, those are just the broad strokes. You can learn more about that from our book available in our bookshop, which is on um, bipolar disorder in children and its manifestation. But Angela, uh, I want to give you time to talk about this from the standpoint of trauma.
Yeah, medications can certainly be used to treat the symptoms of trauma that someone might be experiencing, perhaps an SSRI to help with anxiety and depression. Or if that person is having severe agitation and nightmares, they might get something more significant, like an antipsychotic. But the reality is that the medication is going to be treating only the symptoms and it's not getting to the root of the problem, right? So they really need to be utilized in conjunction with psychotherapy, which is going to be the most effective treatment. Therapies like CBT that you talked about are effective in trauma. There's actually a trauma-informed CBT process, cognitive behavioral therapy. And it really just helps the person reframe their thoughts about the event and turn it from, oh, this was so scary and detrimental to, wow, look, I'm okay. It's going to be okay. It might happen again, but now I have plans for that. All of those kind of really negative thoughts that a person can carry, it helps transform those. EMDR is another process that is really beneficial for trauma. It's eye movement desensitization and reprocessing. You have to say it super slow or it doesn't come out. And that process helps a person process the emotions from the event. But also, what it's doing is it helps them, I like to use the term refile. It helps them refile the event into their brain in a space that allows for daily functioning and keeps it from inverting itself into every aspect of their life. So EMDR can be really, really effective for that as well, and helping a person work through and understand, yes, this happened, but now I can put it back here because I'm done with it, right? It's finished. And then sometimes exposure therapy is also used. And it's an option to expose a person to their triggers from the traumatic event in a safe environment, in a way that's going to help them control their reactions to those triggers. And so then when they experience them again in the future, if that's the case, they're able to understand that I know how to handle this. This is okay. It's not going to hurt me. All of those kind of positive affirmations.
Okay, so we are, I'm sorry, I became distracted for just a second by the questions in the Q&A. Just going to scan those for a moment to see if there's something we want to integrate at this moment. But let's talk for a minute about some of the key differences between trauma and bipolar disorder, where we have, really talking about things that don't exist in one or the other. And I'm thinking that, in fact, in part because of a question that came in through the Q&A about disruptive mood dysregulation disorder. And people think that disruptive mood dysregulation disorder is basically bipolar in children, when it's not. Disruptive mood dysregulation disorder is a separate disorder that actually is distinct from bipolar. And part of the diagnostic criteria that is listed in the DSM for DMDD states that it cannot be assigned as a diagnosis if there has ever been a manic episode. And so they are, in fact, distinctly different. And one of the reasons why the DMDD diagnosis is given so frequently instead of bipolar is that there is a sort of misconception that bipolar can't exist in children, or there is a misconception that somehow it's not appropriate to give a child such a quote big diagnosis. But the reality is that being able to identify mania and being able to treat it early is our best tool for long-term positive outcomes. Delaying accurate diagnosis is a contributing factor to long-term negative impacts of the illness. And so this is a really, really key feature, is that bipolar disorder is the only diagnosis that truly experiences true manic episodes, with the exception of schizoaffective disorder, bipolar subtype, where both the bipolar disorder is diagnosable as well as schizophrenia. But again, that's pulling in the bipolar, and bipolar is the diagnosis that includes mania. And so we have these symptoms of mania that are not always recognizable in children because sometimes they are manifesting differently from how they appear in adults. So for example, hypersexuality is a very difficult bipolar mania symptom to be able to identify in children, especially those who are prepubescent, because they may not have the context or understanding for what it is that they're feeling. And so it may, and again, we go into detail on this in the childhood bipolar seminar that we've hosted, as well as in the book that's on our bookshop, in that it will look different. It may not be readily identifiable if you're looking for adult symptomology. Another example is the excessive spending that can occur in adult bipolar disorder. Children don't have access to money or credit cards or things that could result in excessive spending. So we have to look for that impulsivity in other ways. Irritability, for example, is a symptom of both depression and mania in children. And so when one key difference between the two that we really can hone in on is, has mania occurred? Is that happening? If so, then that is unique to bipolar disorder. Angela, what are your thoughts on mania as associated with trauma?
Yeah, I apologize. I was also distracted by the chat. Yeah, so certainly individual manic symptoms can be present in trauma. You might see hypersexuality depending on what the trauma was. You likely will see increased alertness or hypervigilance. There are a lot of those pieces that can happen. You can see sleep disturbances, outbursts of anger, sometimes even self-harm. But all of these symptoms are going to be, again, in connection to that preceding event. They are not true manic episodes, and they don't cycle like bipolar, like you might see in bipolar either.
Now, what about psychosis? Can you talk about psychosis? Can't that happen in both bipolar and trauma?
It can. Psychosis is not necessarily something that happens all of the time, but it can be present. The reality is, I surprised I haven't said this yet, that trauma changes the brain. And so that changed brain can definitely trigger psychosis, especially if there are other contributing factors. If you're dealing with genetics, if you're dealing with multiple stressors from the environment. that can increase the likelihood of a psychotic episode happening. Um, Delusional thinking, dissociation, hallucinations are all possibilities, but these symptoms are often going to be associated with feelings of safety and protection. And so the person is developing delusional thinking or hallucinations as a defense mechanism against the trauma that they experienced. Dissociation is another one that may happen, but they might lose track of their body and mind. But what's happening is it's just a maladaptive coping strategy for the trauma that they've experienced.
Yes, and in bipolar disorder, when we are seeing psychosis, we're really looking at the fact that we're talking about delusional beliefs. Um, these things are sometimes reality based. We would call them a non-bizarre delusion, a delusion that I have that someone doesn't like me, or that I made a mistake that I won't be able to rectify. But then we also experience the what are called bizarre delusions, things that can't be connected to a possibility that in reality this is happening. And so here, what we really need to do as providers is not just take the the delusional belief at face value, but we have to look in and figure out what is driving it. What are these symptoms of psychosis coming out of? What is causing them to occur? And again, if we can not find any sort of external preceding event, and we are really looking at an internal biological function that brings these thoughts on without any antecedent, then we're able to identify that this is something that is occurring as a result of a chemical disruption associated with a mood disorder rather than something that is trauma based. Someone in the chat is asking for examples of developmentally appropriate symptomology for mania. So I think what you're asking that is, what does mania look like in kids? Mania in kids, and again, we have for free on our YouTube channel our previous seminar on childhood bipolar disorder, and you can get a lot more details there. But mania in children can very often look like irritability, rigidity, refusal to follow simple instructions, usually by ignoring them. There is something that we refer to as mission mode, which is when the child becomes hyperfixated on something and cannot be diverted. There are also a lot of questions associated with how that can be differentiated from ADHD. We also have a book on that and a free presentation clinical seminar on our YouTube channel associated with that. Um, and but what we're looking at when it comes to the mood disruption is that that redirection is impossible, and when forced out of that thing that they have sort of have a mission to complete, it can result in explosivity, irritability, aggression, reactive territorial aggression, and either verbally or physically. And so that manic energy is poured into something that they feel compelled to complete. Angela, there's a question here in the Q&A that I think now is a good time to address, which is speaking more about how trauma changes the brain, because that will set us up for our next learning objective.
Yeah, so one of I call it my pocket mantras is trauma changes the brain. A changed brain is changed behavior. Changed behavior requires changed parenting. And so if you're dealing with an individual with trauma, it's important to remember that dealing with them is going to look different, specifically for children. Parenting them is going to look different than how you might have been parented. And it really comes down to the fact that the trauma causes the amygdala to increase in size. And we already talked about how the amygdala was growing faster than the prefrontal cortex, which helps you with those good decision makings, wise choices, logical thinking, all of that. And so if we're adding something that's allowing the amygdala to grow even faster, that gap in reasoning is going to get bigger. And so what happens is then children and people from trauma are observing situations that may not be problematic, but they're seeing them as problematic because their amygdala is constantly saying, "Whoa, trouble, trouble, trouble." And so that's the main change that I think affects symptomology the most.
We have a comment here in the chat that I wanted to address, which was a person saying that they found that mania is a lot like ADHD, but as a provider, they feel safe with the ADHD kid in the room, but with a child who's experiencing mania, they don't. And I wanted to sort of call that out because it's very similar to something that a psychiatrist we work with said that with the child who has ADHD, you're going to look at them and think to yourself, that must be exhausting. When you are looking at a child who is experiencing a manic episode, the emotional response from the provider is, this child exhausts me. And if you're interested in more information about differentiating ADHD from bipolar, I do encourage you to go check out our YouTube channel. We do have information there. We also have it on our website and in our bookshop. Okay, so our next topic here is identifying some of these overlapping symptoms and really parsing how does it present in bipolar versus how does it present in trauma. And so let's start with that thing that we were just talking about, which is that physical and possible verbal and possibly physical aggressiveness. When that happens for a child who has bipolar, there again, there's no identifiable external trigger for why they've behaved that way. And with bipolar, and this is pretty important, that aggression, be it verbal or physical, is almost always territorial and reactive in nature. So there is something they are being asked to do. There is something that is coming into their environment from the outside that they are pushing back against. And they may not have any idea why. They just know that in that moment, that is something that is intolerable. And so as a parent or a teacher or other authority figure, it's very difficult to parse why today when I asked you to put on your shoes, there was a huge reaction, and why yesterday when I asked you to do it, there wasn't. Why is it that today you absolutely will not tolerate being given chicken nuggets for dinner, but tomorrow you might love them? And so it's not only that there's nothing specific to pinpoint externally in the moment, but it's also that there is no pattern to that aggressive response to that particular stimuli. It's different in trauma though, right, Angela?
Yeah, so there may often be physical and verbal aggressive outbursts with trauma. And again, it goes back to what I said, trauma changes the brain. And it's a lot of times in connection to safety and protection. And when that amygdala is overpowering the prefrontal cortex, so those emotions are overpowering the ability to be like, whoa, this isn't a smart choice. Whoa, you didn't think this through. There's a heightened fight, flight, freeze response. And so when a person is in danger, or most often when they think they're in danger, even though they're not, perceived danger, they're going to jump to that fight, flight, freeze response. And that often includes physical aggression and verbal aggression. And the difference between the strength of that response and the ability to use the prefrontal cortex and say, hey, I'm going to think this through because if I do this, it's probably not going to end well, and to express their needs appropriately. All of that takes a lot of time to learn and to build. And quite honestly, they just don't have the capacity at this point to problem solve or express their feelings appropriately because it's not strong enough to overpower the danger, danger, danger signal.
The next symptom we're going to talk about is self-harm and suicidal ideation. This is a tough one to talk about. So I just want to warn folks that we are going to be touching on this now. In bipolar disorder, self-harm and suicidal ideation occur commonly. In fact, there are estimates that anywhere from 25 to 60% of individuals who have bipolar disorder make an attempt on their life at some point over the course of their illness. And it has a very sort of specific purpose when it is being addressed in terms of a mood disorder like bipolar, in that the true self-harm is driven by the pain of the symptoms, and that the self-harm is viewed as a way to manifest that pain in some sort of tangible way, um, and or it is a way to channel impulsivity that comes from a mixed mood episode where depressive symptoms are occurring, but the energy levels associated with mania are occurring at the same time. This is a very dangerous mood episode for someone who has bipolar disorder because they have the depressive impulses to self-harm, while they also have the energy of a manic episode that will allow them to act on those impulses. And it can also be seen as what is, to the person who has the illness, a reasonable option compared to the prospect of having to continue living in the extreme pain and suffering that they're experiencing. There was a famous author who took his own life, and he once described the idea of suicide as associated with his mental illness, that it was the difference between burning to death slowly versus jumping out the window and ending it fast. In both cases, death was inevitable in his mind, but one felt like taking agency and control, whereas the other one felt like being a victim. And so these nuances may not, to our mind, externally observing and judging, seem like acceptable, uh, or I should say acceptable justifications for taking one's own life. But it is the internal logic that a person with this disorder may be going through as they are assessing the value of their life. And so that is a very specific um, case with mood disorders. Um, Angela?
It's certainly something that can be seen in trauma as well. It often correlates with the impacted self-worth from the traumatic event. So self-harm can be a way to decrease or even eliminate for a short time the feelings of worthlessness, of self-loathing, um, of that are because of the event that happened. So often traumatic experiences lower self-esteem as well, impact relationships, decrease self-concept, and it makes it difficult to trust people. And what we know is that all of those pieces, self-esteem, relationships, trust, are really protective factors that are going to then be missing. And self-harm and even suicide becomes the way that they find solace.
So now let's circle back and talk about the symptom that we've touched on a couple times already, which is impulsivity and risky behaviors. In bipolar disorder, when we're looking at impulsive and risky behaviors, we're really looking at unwanted intrusive thoughts, thoughts that require a lot of energy, as I mentioned earlier, that goes along with mania. Um, and they are usually tied to some kind of internal biological drive, a need that we have as humans that needs to be fulfilled. This is why we may often see risky behaviors in manic episodes like hypersexuality, because this is sort of a basic human need that has been identified, going all the way back to Freud. And so being able to recognize when these sort of unwanted push, these unwanted thoughts driving us towards these sort of basic human expressions, um, those are usually going to be associated with the mood disorder. Um, and again, we talked about mission mode, that there's a specific thing that has to be done. A great example of this is and parents of kids who have bipolar disorder will describe this happening over and over and over again. It's 5 minutes before bed, and that is when the child decides that all of the books have to come off the bookshelf and be reorganized based on some sort of very specific and or random uh, organizational method that they've just come up with in the moment. And any attempt to redirect is going to be met with aggression and hostility and irritability. Um, those types of missions can occur at any time of the day, at any point. They may be completely disconnected from what's going on around them, and they're fundamentally driven by sort of this unwanted intrusive thought that they have to complete or get rid of in some way before they can de-escalate and move on.
In trauma, it's going to again come down to that inability to overpower the emotions with logical thought. Because the brain has been changed, the impulsivity and the risky behaviors, they rule. Emotions, pleasure, desire, reward center is all much stronger than the ability to be like, that's not a good idea. And so they simply don't have the ability to think through situations, to plan ahead enough to recognize that danger is going to be happening, because the emotions and the pleasure and the desire win over that.
Now, nightmares is a symptom that occurs in, as all of these are that we're listing now, that occurs in both trauma and in bipolar disorder. And so it's really important here to be able to tell the difference. Like, is this nightmare experience happening as a result of a mood disruption or as a result of trauma? And in the case of bipolar disorder, nightmares are not always remembered. This is really important. The dreams themselves can be traumatizing. Um, they are frequently not based on personal experiences or reality. They are often violent, they are often gory, and to be honest, they can be very confusing for providers to hear, for teachers to hear, for parents to hear about, in part because it does often seem so disconnected from anything that they know about the child's life. There are also certain themes that run through the nightmares associated with bipolar disorder. So in bipolar disorder, those nightmares are often based around loss, abandonment, pursuit. In the subtype, newly recognized subtype known as fear of harm, those nightmares often involve serious harm coming to the child, serious harm coming to those who they love. There is a we have anecdotal evidence to suggest that the content of the dreams is similar across children, across setting, across culture, despite the fact that they don't interact with one another. They often have themes of being pursued and violently maimed or killed by wild animals. And these dreams occur in children who have never had any kind of scary, traumatic, or problematic interaction with an animal. They may never even have seen that animal in real life. It is not based on things they've seen in movies or television shows or had read to them. Very commonly, when describing nightmares, parents will say, I have no idea where he even came up with this idea because he's never been exposed to it anywhere. And these nightmares can occur as young as, infancy, ages 1, 2, when the children are very obviously experiencing a nightmare or even a night terror, but they are not old enough to be able to articulate their content. But when they do, they are able to identify later on that those nightmares went back all the way to the very beginnings of their memory. That is not the profile in trauma, though.
No, and although the nightmares that children with or adults with trauma have can be very vivid, they can be very violent, they can be very graphic, similarly to what you described. It's almost the opposite in that there are reasons for them. There are usually the thing that they've seen. They're replaying the traumatic event. And they're taking the person back to the experience to relive those heightened feelings. So it's not something that is, I've never seen a bear and now I just had a nightmare about a bear. It's what they experienced typically. And they wake up remembering that and reliving what they felt during that time.
Another symptom that we already mentioned that is sort of only present in bipolar is that mania. You discussed sort of how some symptoms of mania can be present in traumatic responses, but that the manic episode itself is distinct to bipolar. And also, I want to mention that within the FOH diagnosis, temperature dysregulation is a key identifier and what's considered a biological marker for that disorder. And so symptoms of temperature dysregulation really need to be identified and clarified to determine whether or not it is associated with all of the other symptoms associated with FOH and bipolar or not. Any symptom that is really sort of unique to trauma and not bipolar that you want to mention, Angela?
I think one thing that happens with trauma that I don't believe is the same for bipolar is that someone with trauma is going to typically actively avoid the triggers that have connection to the event. They recognize that not always, but often they can make those connections. For instance, if a child was bullied in a school bathroom, they may avoid using the bathroom at school. They may avoid using the bathroom altogether without their safe adult. And it's my understanding that this same level of specific avoidance of triggers is not always the case with bipolar.
That is an excellent distinction. In fact, because with bipolar disorder, a lot of parents are desperately trying to figure out what the pattern is. Why is the child avoiding something one day and not another? And this is a really precise differentiation mark. Avoiding those triggers will be sort of pointing us in the direction of trauma as the cause. Now, I want to get into sort of describing gold standards for diagnostic assessments and how to identify appropriate treatments for managing both of these conditions. But I want to sort of throw something out that we probably should have addressed right off the bat. In the misconceptions session. And that is that one of these disorders is better or worse than the other. That the idea that, we don't want to diagnose a child with X, so we're going to diagnose Y instead. Trauma and bipolar disorder are different disorders. They are equally serious. They are also equally manageable. There's a misconception specifically about bipolar disorder that having it is like a life sentence, um, that it is full of you know no hope for the future. We have a member of our community who is a parent who actually had a teacher say to them when their child was in first or second grade, um, I know families who have kids with bipolar disorder, and let me tell you, it will never get better. This is a horrible thing for a parent to be told, and it is absolutely not true. Bipolar disorder is a manageable illness. And the sooner we recognize it, the sooner we provide appropriate interventions and treatments, the better the outcomes are. I'll let Angela speak to whether or not that is also true for trauma, but it is definitely the case in bipolar disorder. And so I want to really hammer home the idea that trauma, bipolar, ADHD, major depression, borderline personality disorder, whatever the diagnosis is, they are not ranked in some hierarchy from worst to best, or best to worst. They are different diagnoses. They both require different types of treatment. They all require slightly different types of treatment, um, but they are all manageable if we choose to use the gold standard treatments that are designed for that disorder. So treating bipolar with trauma interventions or treating ADHD with bipolar interventions isn't going to get you where you need to be, but it's manageable when we align the diagnosis with the gold standard treatment. Angela, do you want to add anything to that?
No, I think that that's a really important point. Any diagnosis can be significant if you're not doing anything about it. And so both diagnoses have the opportunity to get appropriate treatment for a stable and healthy life. With trauma, with the appropriate treatment, you're going to see the decrease in those symptoms, but a person may still have traumatic triggers for the entirety of their life, depending on what that trauma looked like. But again, if we're getting the appropriate treatment and we're doing the work, for lack of a better term, to realize what those symptoms are and creating appropriate coping mechanisms, they all have the opportunity to be successful individuals.
So, in light of that, we're going to describe some of the gold standards for diagnostic assessment that are uh, some of which are across the board useful for all mental health diagnosing and treatment. And that first sort of gold standard piece, and actually Dr. David Miklovitz, who is out of UCLA, he has written the book, The Bipolar Survival Guide, Living Well with Bipolar. You can check out our YouTube channel for a conversation that we recorded with him earlier this year on his book, Living Well with Bipolar. But in the Bipolar Survival Guide, he talks about the sort of gold standard for treatment. And it always starts with a structured interview. That no matter what the diagnosis is, that spending 1 to 2 hours, sometimes 3 or 4 times in that 1 to 2 hour session, in order to pull in the necessary information. This involves a very detailed history of development. Oftentimes, providers are taught to sort of look at the last 4 months, the last 3 months, the last 6 months, or to only look at the moment from which someone externally has identified that symptoms began. But being able to go back and get a developmental history that is biological from physicians, from their pediatrician, from their teachers, from their caregivers, from non-parental caregivers, from the patient themselves, being able to get that holistic history that is not only based on documentation, but is also based on structured interviews are extremely important in terms of developing detailed family history, a decent patient history, a decent history of the illness, a decent understanding of the interventions that have already been tried, whether they have been medicinal or psychotherapeutic or a lifestyle intervention. Being able to holistically view all of this information is extremely important to that diagnostic process. So that means reviewing medical records and the like. Angela, what did I miss? What do you want to add to that?
I think that that was very comprehensive. Again, because trauma is going to be from a preceding event, it's going to be important that you're getting that information. If you're just going with, oh, they're impulsive, they don't sit still, they interrupt, you're going to check off all the boxes for ADHD, and you're never going to get to the fact that this big thing happened, and was the the beginning of where all of this started. So I think it's really, really important to take the time to build that trusting relationship and get all of that information, or else you have a higher likelihood of a misdiagnosis.
And I love that you said build that therapeutic relationship. In bipolar disorder and mood disorders in children, to some degree also in adults, but most especially in children, that therapeutic relationship building period is extremely important. We tell providers whatever you have allotted in terms of your rapport building phase, double it, triple it, quadruple it, multiply it by 10. That's how long it is going to take for you to be able to build a truly effective therapeutic relationship with this child patient. Because with a mood disorder, they have very often either experienced nightmares or other symptomology that made them have difficulty trusting adults, or they have been given these medication trials that were designed, as I mentioned earlier, to fail, so that they could help to rule out or rule in bipolar disorder. They have spent years being told by adults in their environment that they need to change their behaviors, when in fact they're experiencing involuntary symptoms that they cannot make change in and they feel victimized by. And so coming into the authority figure's office and being told to trust them is never going to be sufficient. And so, depending upon how long a child has gone without an accurate diagnosis and effective treatment, you're going to have to add time to that rapport building phase so that you can get this child to actually trust you. One of the things as a clinician that I always say to patients and clients, regardless of their age, is I can't just tell you to trust me. You have to experience me as trustworthy over an extended period of time for you to truly believe that. And that is always the case with children. They must experience you as being trustworthy over time in order for that rapport and therapeutic relationship to exist. Um, is there anything different when it's trauma, Angela?
No, I was just going to add on that trust piece is so essential, right? So a child or even an adult who has experienced trauma, their brain is looking at everything through a lens of danger, like I had mentioned, and that includes people. I saw a question in the chat come by: why do you see children act and respond differently to different people? And truly, it's because of their perception. It's because that maybe dad always wears a red shirt, and red is very triggering because when I had my traumatic event, everyone had on red shirts. It can be something as what we would term silly as that. Um, so building that safety and helping them remember and retrain their brain that this is a safe space. I am a safe person. All of that is really, really significant. And it doesn't come with just saying, hey, it's safe here. You can talk to me, or hey, the door is locked. This is no big deal. Yes, those are all aspects of safety. Right at night, I walk around, I make sure our doors are locked. I make sure that the windows are closed. I make sure that the stove is off. My dad taught me that. All of those pieces. But felt safety is what really is the essential portion of this, right? And felt safety is that body and brain connecting to say, I am safe. And the way that people feel safe is different for everyone. I sleep with my bedroom door closed. That makes me feel safe. I have friends who are like, absolutely not. I need my door open. If someone comes in my house, I want to know. And so those are the pieces of safety that you really have to think about is what does this person need to feel safe to be able to engage in this relationship?
Absolutely. Absolutely. And then, part of the gold standard for any diagnostic assessment is doing a true differential diagnosis. Because, Angela, as you mentioned at the very beginning, like trauma and bipolar disorder can coexist. They can both be happening at the same time. People can be addressing symptoms from both of those things simultaneously. There can also be other diagnoses. ADHD and bipolar can coexist. ADHD and trauma can coexist. I mean, we could go on and on forever with the list of things that could coexist. And so doing the differential diagnosis is really, really important. This is one of the things that we do as standard practice in our diagnostic consultations. And we do this to support families, but we also do this to support providers, because sometimes doing a full differential diagnosis is very time consuming, because you have to look at all of the possible diagnoses that these symptoms can appear in. And then you have to drill down on all of these detailed pieces of information that help with differentiation that we've been outlining over the last 75 minutes. And so being able to do that, to say, I am going to rule in or rule out every diagnosis that these symptoms appear in, is time consuming, but it is essential to being able to feel confident that the diagnosis you ultimately give is based on that individual client's symptom presentation, and not just that these symptoms often correlate with one of these other diagnoses. Part of that differential diagnosis is also to make sure that you offer your diagnostic impressions and review any conclusions from your evaluations with the client, because you want at every step for them to be able to correct, to clarify, to give you additional information that will help to inform that. You need to present all of that information to the client so that they can have that holistic understanding of where their symptoms align and where they don't. Um, Angela, what have I missed and forgotten?
Again, you were really comprehensive. The only thing that I think I would add is there is a necessity to do that medical records background, right? We talked about how sometimes there's a medical component that we might not know about. But when we're talking about trauma as well, even getting that medical information, there may need to be a step further depending on what happened, what the traumatic event was, and to just ensure that there is not more medical needs that need to be addressed. If there was an assault, for instance, we would want to ensure that there are no new medical concerns because of that. But I think that, again, that's just a small piece of all of that history and information taking that you do at the beginning.
Um, what we're going to do now is we're going to just sort of dig a little deeper into these questions that are in the Q&A, so that we can answer the questions that you have coming up. And I want to just stress that we've striven here to provide you with factual information on differentiating the symptoms that can overlap and co-occur in trauma cases as well as in bipolar disorder diagnoses. Um, I will try as we go through the questions to make clear what pieces of our answers are our opinion as professionals, as opposed to what is fact-based from the DSM. And I say that because I'm going to start with a question here about ODD, oppositional defiant disorder, and whether it is more closely related to bipolar disorder or trauma. Because the answer I'm going to give here is not fact-based. The answer I'm going to give is based on my experience as a clinician. And that is that ODD is a diagnosis that I don't like. I don't think it is appropriate to give to children and teens, in part because it is based on the idea of compliance with an authority figure's requests. And I don't think that we can pathologize a child or adolescent based on their response to the request being made to them from an external authority figure. Yes, children can become oppositional. Yes, teenagers can be defiant. Yes, these are characteristics of some symptom profiles, but I personally don't believe that just because it's in the DSM, it is a diagnosis that should be used. And as an individual clinician, I have the right to decide not to utilize it in my practice and in my work with families. ODD to me is a series of symptoms that can or cannot appear in many, many diagnoses, but it is unfair to diagnose children with that specifically. So to address your specific question, um, oppositional behavior, defiant behavior, symptoms that trigger those behaviors can occur in bipolar, they can occur in trauma, they can occur in ADHD, they can occur anywhere. Will they manifest differently depending upon the child? Yes. Will they manifest differently depending upon the disorder? Yes. We couldn't possibly give you any sort of comprehensive set of examples of that, but to know that as an authority figure, you know opposition and defiance when you see it, and it can present itself at any time and in any way. Angela, is there a question you want to address?
I was just gonna tack on to ODD. I feel very similarly, but I I think because it's the symptom portion that you talked about, right? We see ODD and we're just looking at the symptoms. We're just looking at the tip of the iceberg and we're not digging down to the whys. And we talked about in the beginning how important those whys are. Why are they having impulsivity? Why are they being oppositional? And that looks very different in multiple disorders. And if we're not taking the time to suss that out, then we're doing a significant disservice to the children and families that we're working with.
Absolutely. We have a great question here. What types of differences in symptoms do you see in people of color? This is incredibly important because the diagnostic criteria, as it's written in the DSM, really is written for white American of Western European descent males, adults. And so when you sort of pull the lens back and say, okay, well, how does this apply to a child? How does this apply to a person of color? How does this apply to someone who's gender nonconforming? Like, how does this apply to other groups? It changes it. And what I would say, again, based on my clinical experience, is that the symptoms themselves don't differ. What happens is how those symptoms manifest differs, how those symptoms are recognized and identified by others are significantly influenced by these demographic factors. In part, we see this commonly in the fact that young girls who are Black are very often seen as being aggressive and hostile when they are not, when they engage in behaviors and communications that are identical to non-Black children, they are still identified as being hostile and aggressive. That is not, I'm going to stress this, that is not because there is something about the child that justifies that. That is because that is based on a discriminatory or prejudicial perception of that child from the observer. Now, is that to say that Black children can't be aggressive and hostile? Of course they can, just the same as any child of or adult of any race can. But it is through the perception of the observer that it becomes problematic when it is being applied, when it doesn't belong as a result of some sort of characteristic that is being interpreted and judged by the observer. So I would say that if you are dealing with a person of color, if you are dealing with someone whose demographics are different from your own, best practices dictate that we use culturally appropriate lenses to view behaviors, to view symptom presentation, and to understand the context for that symptom manifestation for that individual. We never want to use just a cookie cutter response to any of our clients. We really want to drill down on what is specific to their experience. And that's going to be true whether we're talking about race, religion, ethnicity, or anything. So I really would encourage anyone who has concerns that their child or loved one is not being diagnosed correctly because there is some bias as a result of race or any other category, to find a provider that you feel comfortable is going to see you as an individual and take your cultural, racial, socioeconomic background into consideration when they're doing their assessments. Angela, did you have anything to add or a question that you wanted to address from the chat?
Um, I was just wanting to reiterate that in trauma as well, the symptoms are probably going to look similar, but as a provider, it is important to remember that racial trauma is real, right? So the discrimination they're facing, the things that they are going through does look different than what I'm going through as a Caucasian adult. And so all of that changes how the effects of the event for them. And so remembering trauma, we can experience the same event, but it's the effects of the event that is what's really causing the traumatic symptoms. And so just remembering that everything that you just said is really, really pertinent.
There's another question here that I wanted to answer. Oh, sorry, Angela. What were you going to add?
Nope, go ahead.
Okay, so there's a question, are there particular screening tools for children under 8 years old and for other children, older children? Yes, so if you're talking about bipolar disorder specifically, there are two measurements that we highly recommend. We are not associated with the folks who own it. They do charge a fee for the scoring, although that is not required. And those are the Child Bipolar Questionnaire and a questionnaire that is called the Janie and Jeffrey Illustrated Interview for Children. And the Child Bipolar Questionnaire and the Janie and Jeffrey are assessments that were designed and validated specifically around identifying bipolar disorder in the pediatric population. The CBQ, the Child Bipolar Questionnaire, is filled out by parents at home. It takes 20 minutes. Once it is scored, they can access not only their answer sheet, but also their scoring sheet, which can be then submitted to you as the provider for review. The Janie and Jeffrey is the only, or at least it was the only, I'll say it's the first, because I can't be totally confident something else hasn't come along, but it's the first validated measure that the child takes themselves, and it is effective up to, I believe, age 16. And those have actually pictures on them depicting a child experiencing each symptom, and then it asks the child to score on a Likert scale how frequently and how intensely they experience that symptom. And again, the parents can get the answer sheet as well as the score sheet, submit them to you for your review and assessment as the provider. And they're extremely valid measures. I believe the CBQ has been validated at a 96% rate. So it's a very, very useful tool. You can get to it simply by Googling Child Bipolar Questionnaire, Papalos, Papalos. Dr. Papalos, he's the author of the book, The Bipolar Child, and he is the research director at the Juvenile Bipolar Research Foundation. He is the one who led the team that developed those two assessments, so you can find them online that way. Angela, is there an open question you would like to answer?
Um, I you keep asking me that, and I have answers to the question you just answered.
That's fine too.
I just wanted to mention that there are questionnaires for trauma, but most commonly it's the Adverse Childhood Experience questionnaire that's going to give good information when we're speaking about children. And that's the questionnaire from the Kaiser Permanente study that I discussed earlier. It's going to ask about 10 specific events, but that I guess tend to be the most common. And so that is utilized in a lot of screening. I know that, children that I have, my personal children who are in there, I fill that out on a regular basis, like every third month or something, to make sure something new hasn't happened. And so that gives a lot of good information as well.
I am writing in an answer here to a question about the book author. Again, his name is Dr. Dimitri Papalos. I'm putting the answer into the chat now. The book is called The Bipolar Child. I believe the subtitle is a reassuring guide for parents. It is, in fact, that. Dr. Papalos is, as I said, also the research director at the Juvenile Bipolar Research Foundation. They he has done a number of live events with us here at CMHRC, and you can go to our YouTube page and you can look at the seminars that we've hosted with Dr. Papalos. He has also been to our book club. You can find a link to his book on our book club page if you'd like to buy it, and use our affiliate link so that we get a couple of pennies for your purchase. Uh, I also want to point out that this event is differentiating bipolar disorder from trauma in clinical practice. We have also had events on differentiating ADHD from bipolar disorder, differentiating borderline personality disorder from bipolar disorder. And these are all conversations that we have with providers all of the time, and are going to be part of a conference that we will be holding in October on bipolar disorder. On October 23rd and 24th of this year, we will be hosting a 2-day live virtual conference on bipolar disorder in childhood, where we will be talking not only about the details on the diagnostic process and the background on the disorder, but we will be talking about differentiating it from others. Disorders such as these, we will be talking about the newly identified and recognized phenotype known as fear of harm, and we will be offering continuing education credits for providers through the National Board of Certified Counselors, as well as through the Association of American Association of Family Physicians. So if you're interested in that, please be on the lookout for our September newsletter, which will announce this officially and have links to get more information on how to register for that important 2-day event. For those of you who have asked about other topics, such as differentiating OCD from bipolar disorder and trauma, differentiating autism from bipolar disorder, we appreciate those suggestions. We are always working on new seminars and opportunities to provide psychoeducation to families and providers on topics that are relevant to you. So we appreciate your feedback. Angela, anything we want to add before we wrap up since we are at time?
Yeah, I just have one final thing to say. I think often that people use the word trauma and traumatic and PTSD. They throw it around loosely. You know, something scary happened, it was trauma. And I just want to emphasize that there are real life altering symptoms associated with trauma. And it's not my or someone else's prerogative to decide how an event affected a person. If someone is having symptoms from something that you're like, that was really stupid, it's not up to you. It's not your body reacting to the event. And so I just think that it's really important for people to remember and realize because it's easy to step back and be like, I don't know what their problem is. But just because it was not problematic to you does not mean that it's not problematic or have a significant impact on someone else.
Absolutely. And Angela, thank you for mentioning that. I want to bring up one last thing from the Q&A before we go. A caregiver has written in the description about trying to force their child to do something and describes it as it's like trying to nail jello on the wall. That is a wonderful description, and I want to thank you for that. One of the things that we do offer as part of our programs and services is a class called palliative parenting. And it, as I mentioned at the beginning, it is specifically geared to help parents of special needs children parent them in a way that allows them to grow, that allows them to learn, that allows them to be who they are, while we as parents still have to engage in all of the activities of parenting and shaping them into adults. The needs that these children who have these disorders have are different than those of neurotypical children, and our program is specifically designed to address the needs of parents of those non-neurotypical children. It will teach you how to recognize when you are trying to nail jello to the wall and teach you an alternative, so that you feel as though you have accomplished something and supported your child, rather than had a feeling of failure. So if you are interested, our next round of face-to-face classes for palliative parenting begins at the end of September on Tuesday, the 23rd. You can get information on that from our website, cmhrc.org, or by going to palliativeparenting.com to get more information. All right, so next month we will have our webinar on the third Wednesday of the month. It is on discipline and limit setting for children with living with mood disorders. And then our clinical seminar for the month of September, the following week, is on treating the whole family, how having a client with a mood disorder, a child client with a mood disorder necessitates treating the whole family. And we'll take a deep dive into what that looks like. You can register for those two events for free on our website, cmhrc.org, looking under the free resources tab for webinars and clinical seminars. Thank you, Angela, for being with me tonight. This was a fantastic conversation. I look forward to having you with us again. Thank you to everyone for being here. Don't forget to check out our website for all of our free offerings and additional programs and services, and we look forward to seeing you again soon. Have a great rest of your night. Bye, everyone.